So the clinical presentation. So the clinical presentation of patient with posterior fossa pathology varies based on the location of the lesion, the rate at which the lesion is developing, the impact it's having on the cerebral spinal fluid flow, and the intracranial pressure changes it's causing. Lesion in the posterior fossa can also cause focal deficits due to cranial nerve dysfunction, example, ocular palsy, nystagmus, dysphagia, laryngeal dysfunction, and arrhythmias. And again, going back to the anatomy, as it was showing that the nerves from 3 to 12 reside in this area. And so a compression of any of the nerve could cause any of the above mentioned dysfunctions and could present as posterior fossa pathology. Then problem with the respiratory regulation can also be a sign and symptom along with sensory motor deficit or cerebellar sign and symptoms like ataxia, tremor, and motor discoordination. Sometimes it's raised ICP is what the presenting sign is. And if your flow to the cerebral spinal flow is compromised, a large lesion compresses the content of the posterior fossa. The initial presentation can include the signs and symptoms of elevated ICP, which are basically your headache, nausea, vomiting, and your altered consciousness. Now, once we've done the anatomy and how the pathology itself presents, then we start with our preoperative assessment and management. So again, patients undergoing posterior fossa craniotomies require the same preoperative history and physical examination as patients undergoing any moderate to high-risk surgeries. What we are going to focus over here are the preoperative assessments that we need specifically for a posterior fossa craniotomy. So in addition to the usual pre-anesthesia evaluation, we will focus on the neurologic status, including the current and prior deficits, the signs and symptoms of raised ICP, any history of seizures, patients with cranial nerve deficits resulting in dysphagia, loss of gag reflex, and laryngeal nerve dysfunction may require delayed extubation at the end of the surgery, as they may not be able to hold their airway patent. The preoperative cardiac evaluation may be of particular concern for patients who are at high risk for venous embolism. So, as you know, some posterior fossa craniotomies are done in sitting position, and the risk, if the sitting position is contemplated, we obtain a transthoracic echo preoperatively, or perform a transesophageal echo after induction to rule out any patent foramen ovale or other intracardiac shunts. We consider an intracardiac shunt a relative contraindication for sitting position. However, we can discuss this further down, that any position that you make should be a joint decision between the surgical and the anesthesia team, so that the risk and benefits can be weighed and an informed decision between the two teams can be made. Then venous air embolism in a patient with an intracardiac shunt can result in paradoxical air embolism, which can result in myocardial ischemia or infarction on stroke. In addition, patients with pulmonary hypertension or right ventricular dysfunction may decompensate with even small amounts of intravenous air. And so that's why these patients, when they come up into the clinic, if the surgeon is already expecting or thinking about going for a sitting position, then we would prefer to have a transthoracic echo, not just to get a basic baseline cardiac function for that patient, but also to make sure that there is no connection between the right and left systems of the heart, so that if the air goes in, it is not as catastrophic as it would be if there is an intracardiac shunt. Then for the pre-medication, so a lot of these patients are on who are undergoing craniotomy, whether it's posterior fossa or even temporal or frontal craniotomies, for that matter, are taking anti-seizure medications, which can affect the metabolism of a variety of drugs, including your neuromuscular blocking agents. However, patients should be instructed to take their anti-seizure medications, take the usual dose on the morning of surgery, unless the patient is going for a seizure focus mapping. For patients who are on glucocorticoids, they may require a stress dose intraoperatively. And then in most cases, all the anticoagulants like aspirin, Ansis, and other medications that affect the coagulation systems are already stopped in advance stopped in advance of craniotomy to make sure the risk of bleeding is not super high. Then pre-medication for craniotomy should be individualized based on patient's level of anxiety, baseline neurologic status, and comorbidities. So what we discussed in the previous slides, they're usually home medications, the anti-seizure, glucocorticoids, or anticoagulants, apart from the normal home medications. If they are coming from craniotomy, they might be on these medications, and this is what they are at home and what instructions you're going to give. Whereas for these medications, what you're going to give once they are inside the hospital premises for the surgery. So patients with posterior fossa pathology may be especially sensitive to the respiratory depressant effects of benzodiazepine and opioids, and may be at increased risk of aspiration and excessive sedation. So sedatives should be titrated to effect using small doses of medication. So like, for example, midazolam 1 to 2 milligram IV, but should be given in boluses of like 0.5 to make sure that no harmful effect is being taken by the sedatives. For patients symptomatic with neurologic deficits who require pre-medications, we withhold sedation until the patient is fully monitored and in a setting that would allow immediate airway management. So, for example, if somebody has some kind of cranial nerve deficit and is already having some laryngeal deficit, and then on top of that, if you are and then on top of that, if you are already giving them sedation, then that would increase the risk of loss of airway. And so you would only give them sedation once they are in the OR and they are in a controlled setting where, if needed, airway can be secured quickly. Then before we start the induction, when we are doing a checklist with the surgical team, there are certain things that you need to discuss as a team. And these would require your need for planned brain relaxation, including the dose and timing of the necessary medication. So whether the surgeon wants a brain relaxation, and if they want a brain relaxation, what time do they want it at, and what medication are they would they prefer to get that, or a combination of medications. The positioning is a joint decision between the two teams, and so you have to weigh the risk and benefits from both ends, from both anesthesiology as well as surgical perspective, to finalize what position you're going to go for. Then, depending on that, there's always a risk of venous air embolism for these surgery. You have to discuss the blood pressure surgical thing, need for doses of anti-seizure medications during the surgery, and then whether neuromonitoring will be used during the surgery or not, as that would affect our plan of anesthesia for that particular patient. Then the second thing, then after discussing all of that, these surgeries for the most part require pinning. And so pinning is one part of the procedure which is very stimulant, but is very short-lived. And after pinning, they would go and then scrub and come back in. So it's like, it's a stimulus. It's a very stimulus, but very short period lived. And so you can avoid the hemodynamic changes that happen during the pinning by using opioids for minimizing hypertension and tachycardia. During skill pinning, include administration. So opioids that you can also use esmolol 0.5 to 1 milligram per kg. You can use propofol 20 to 50 milligram bolus. Some people also use lidocaine in a dose of 1 milligram per kg, and rarely people give nicardipine as well, 0.5 to 1 milligram, but that's also present in literature. So the literature says that these are the things, or the combination of any of these things you can give to prevent skill pinning. You have to give something for pain, and you have to give something for your hemodynamics, whether it be a beta blocker or alpha beta blocker or a propofol, for that matter, along with some kind of an opioid gives you the best result. Now, Apart from that, the other thing that we can do is local anesthetic infiltration at pin sites or scalp blocks. So depending on your site, uh, uh, some sites have the capability and the skill set to do scalp blocks. However, at most sites, local anesthetic infiltration is preferred over scalp. There have been some studies that are superior, but part and scalp blocks have a similar result for pain post-operatively in first 24 to 48 hours. Then after that, we need to discuss about the monitoring that is needed for this surgery. So we're going to start with the electrocardiogram. Uh, Again, these monitoring are mostly specific for posterior fossa. You're going to do the standard monitoring that you would do for other surgeries, but these are specifically for posterior fossa. So the ECG can provide indications of traction or manipulation of kidney nerves on the brainstem during surgery and allows adjustment of retractors or instruments. Brainstem manipulation or traction on cranial nerves 5, 9, and 10 can produce abrupt, profound bradycardia or transient asystole via increased afferent activity and the resulting vagal response. If this happens, then you need to notify the surgeon immediately. The heart rate generally returns to normal or rebounds when surgical stimulus is adjusted, but administration of an anticholinergic like an atropine or glycopyrrolate or an epinephrine may be necessary to temporarily get the heart rate back up. Rarely do chest compressions are required to circulate the medications if the asystole does not resolve after release of traction. Bradycardia may also signify an increase in intracranial pressure, particularly when it's associated with hypertension. Then for venous air embolism, what monitoring? So like we discussed previously, that venous air embolism is a risk factor for the surgery. And what are the monitorings that you can use? Sorry, what are the monitors that you can use to not decrease the risk, but identify venous air embolism earlier? So the available monitors that we have include precordial Doppler, transesophageal echo, and capnograph. So the first signs on VAE on monitoring device are typically visible air bubbles on TEE. So TEE is more sensitive. And then simultaneously, there's a whirring sound on the precordial Doppler, depending on the rapidity of progression and the patient's ability to compensate a drop in end-tidal carbon dioxide will occur. And a significant drop in EtCO2 usually precedes a drop in arterial blood pressure. So the earliest one to catch is TEE, followed by precordial Doppler, and then it's the end-tidal carbon dioxide. And after that is what you're going to see a hemodynamic instability. So for these three, if we go one by one, so if you start with capnography, a sudden flattening of the capnography waveform and reduction in end-tidal CO2 greater than 5 millimeter hydrocount during sedated neurosurgery may suggest VAE in mechanically vented patients. However, this finding is non-specific. The end-tidal drop during venous air embolism. The end-tidal drops during the venous air embolism, which basically obstructs the pulmonary vasculature and results in the areas of lungs that do not exchange gas, thereby increasing the total anatomic as well as physiologic dead space and reducing the expired carbon dioxide. The magnitude of the drop cannot predict the severity of your venous air embolism. If there are carbon dioxide changes without evidence of air on TEE, then other diagnosis of a drop in end-tidal should be explored, like reduced cardiac output from left ventricle preload or cardiac dysfunction due to coronary artery embolism or arrhythmias. So even though end-tidal control does let you know about the venous air embolism, it's not very specific and it is also not very sensitive. But it is better to have nothing. It is better than having nothing. Then the next one we're going to discuss is the precordial Doppler. So a precordial Doppler placed along the sternal border can detect up to 0.015 cc's per kg per minute of air. The Doppler is sensitive enough to detect embolism early and allow the surgeon and the anesthesiologist to respond before cardiopulmonary adverse effects ensure. The precordial Doppler is non-invasive and acts as a constant real-time audible monitor for VAE. What we do is we confirm the correct placement of the Doppler probe by injecting approximately 10 ml of agitated saline through the either venous catheter or a peripheral intravenous line, and listening for an obvious change in Doppler tone. If negative, we reposition the precordial Doppler. The precordial Doppler probe should be placed and secured with tape after the patient is positioned for seated surgery, as the optimal site for the probe may change. Again, this is an important fact that you need to make sure that the monitor you are using is actually in the right position. And so even though if you had placed it in the right position when the patient was supine, but now if you've changed the position to sitting or prone or park bench, now you need to recheck and make sure that then again your monitor is in the right position before you start using it as a monitor. Then is your transesophageal echo, which is the most sensitive monitor for VAE and can alert the anesthesiologist at the first sign of air entry. So TEE can detect as little as 0.2 mL of air. However, TEE is expensive, it is invasive, and requires expertise to place and interpret, and requires that the clinician watch the ultrasound screen continuously. The safety of TEE in long cases with the neck flex has not been established. Devices placed in the pharynx can obstruct the venous drainage in the neck when it's flexed and cause swelling of the tongue and soft tissues with potential airway obstruction after extubation. The TEE probe is placed after induction of anesthesia, and an examination is performed to assess the cardiac function and, if necessary, assess for patent foramen ovale. So again, like we discussed previously, this PFO is important to catch before you start the surgery because, like I said, it's more chaotic and more catastrophic if you have intracardiac shunt and then you have air in your system. Then after the VAE, the other important aspect of a posterior fossa craniotomy monitoring is your neuromonitoring. So in your neuromonitoring, you can use the multiple devices that you can use are your EEG, EMG, somatosensory evoked potential, brainstem auditory evoked potential, and your motor evoked potential. Then this is basically a graph that is showing you the applicable neuromonitoring that can be applied and the type of surgeries there are. So, for example, if you're doing a thoracoabdominal deformity correction, that you would need an EMG, an SSEP, and an MEP. Whereas if you're doing a lower lumbosacral spine surgery, MEP is not required. Only EMG and SSP are fine. If you're doing a cervical spine, then you would need EMG, SSEP, and MEP. If you're doing an intramedullary spinal tumor, you need the somatosensory and the MEP. And then for cauda equina, again, you need EMG and SSEP. For intracranial surgeries, for like neurovascular, you need your EEG, SSEP, and MEP. For supratentorial tumor resection, you need the same as you need for neurovascular. Then your skull-based or posterior fossa, this is what we are doing today. You need an EMG so that you have a safe entry zone for entry. And then your SSEP, BAP, and MEP are required for your posterior fossa tumors. If you have an intracranial seizure focus ablation, then you need your EEG for that. For cardiovascular surgeries, you would need your SSEP. For aortic surgeries, you would again need an SSEP and MEP. And for interventional neuroradiology procedure, if it's an intracranial procedure, again, SSEP, MEP, and EEG may be required. Same goes for an interventional neuroradiology spine procedure, and SSEP, and MEP neuromonitoring may be required. Then this is a graph that I picked from one of the books, which basically, in a very concise manner, is telling you what neuromonitoring is affected by and what is it resistant to. So as you can see in this graph, your brain auditory evoked potential is resistant to volatile. However, as you saw in the previous graph, if you see brain auditory evoked potential, it is only used in very few surgeries. So it is used in posterior fossa, but it's not the only one that is used. You use it along with SSEP, MEP, and EMG. So even though it is resistant, and so it is usually combined with either SSEP or MEP. And so when it's that is affected by your volatile agents, your nitrous, as well as some of your intravenous agents, and it is resistant to your muscle relaxants. The MEP, of course, is affected by muscle relaxants. However, whenever we are doing these surgeries and we are going to do motor evoked potential, we talk with the the neuromonitoring specialist, and I would say 99% of the times they say that you can use your induction dose of muscle relaxant, and by the time they're actually going to start the surgery, the patient would be reversed by then. Or if they're not completely reversed, then before they start, and if they're doing the baseline monitoring, you can give the reversal to make sure that the patient muscle relaxation is reversed at that time. But you can still use it for your you can still use your muscle relaxant for induction purpose and for intubation purpose. Then this graph, so this is a very concise graph. I like this one way more because it gives me a summary of what is affected and how it's affected and what affects it and what is it resistant to. This graph is telling you how is it affected. So, for example, if you're using isoflurane or sevoflurane, they basically decrease the amplitude of both SSEP and MEP, and therefore you would either use it at the low MAC or you would just avoid inhalation and go to TIVA. Same is it's so for all inhalation agents, it's very similar. What they're going to do to SSEP, MEP. For propofol, for barbiturates, they decrease the SSEP amplitude and MEP amplitude. For opioids, etomitate increases at low doses and decreases at higher doses for SSEP as well as for MEP. For the ketamine, it minimally increases at low dose the amplitude for SSEP as well as for MEP. And for the benzos, it has minimal effect at low doses for both the SSEP amplitude and the MEP amplitude. Then we have our dexmedetomidine, which is a newer drug which we have been using, especially in neurosurgery, but of course in other things as well. It also has minimal effect on your SSEP amplitude as well as your MEP amplitude. All right, then after deciding on what things you need for your monitoring and how you're going to do your monitoring, the next step that comes up is the actual induction of anesthesia. So the goals for induction of anesthesia for craniotomy include your hemodynamic stability. So the drugs and doses should be selected to maintain cerebral perfusion pressure while avoiding hypertension and the risk of intracranial hemorrhage. Avoiding increase, and the second goal is you're avoiding increased ICP. So of course the medication and ventilation should be managed to increase ICP. Then your choice of induction agents. So which agent you are choosing is not that important. It is important how you're using that particular agent and the effects that agent is going to have. So that's why we say that the induction agent should be chosen based on patient factors and the effects of the agents on cerebral physiology. With the exception of ketamine, IV induction agents cause reduction in both cerebral metabolic rate and cerebral blood flow, resulting in no change or decrease in ICP. The autoregulation and responsiveness to carbon dioxide are also preserved with these IV induction agents. However, even with a single dose of etomidate, it inhibits the corticosteroid production in the adrenal gland for up to 24 hours. For the ketamine, there is conflicting data, and some human and animal studies have reported that ketamine increases the CPF, CMR, and ICP. By contrast, other studies have reported no change or decrease in other parameters, particularly when ketamine is administered with other anesthetics. Given the uncertainty, we just believe that ketamine should be used with caution for craniotomy, especially for patients with increased ICP. The non-depolarizing ones have no direct effects on the cerebral physiology. For the succinylcholine, can produce a transient increase in ICP, possibly the result of an increase in CPF related to the arousal response to muscle fasciculations. However, the brief increase in ICP with acetylcholine can be attenuated by administration of a defasciculating dose of non-depolarizing neuromuscular blocking agents. For rapid sequence induction and intubation in patients in whom ICP is a concern, we administer a defasciculating dose of non-depolarizing neuromuscular agents. So for example, around 2 milligram of rock or 1.5 of cis, followed by SUX at a dose of 1.5 to 2 milligram per kg of IV, would hopefully decrease the increased dose of increase in ICP that can be seen with SUX. Having said that, in our practice over here in North America, for the most part, when you want to do even a rapid sequence induction, I would say 98% of the anesthesiologists prefer a higher dose rock than using a SUX for any case, irrespective of whatever they're doing. If they want to do an RSI, they just prefer rock for the simple reason that Sugammadex is readily available over here. And so we basically use rock at a dose of like 1.2 milligram per kg rather than the usual 0.5 to 0.7. So we're basically doubling the dose, and that gives us the similar effects to SUX without the side effects of SUX. And the reason why SUX was preferred previously was because it was short-lived, and if you run into a can't ventilate scenario, SUX would get out of the system much quicker than other neuromuscular blocking agents that we had. However, because now we have Sugammadex readily available over here, we use rock at high doses, and if you ever run into can't ventilate, you can always use Sugammadex to return the effects of the rock that we have used. Then the next point of intervention that comes for us is positioning. So there is a midline suboccipital approach which is frequently used to decompress your Chiari malformation or tumor resections and often requires the patient to be positioned prone or sitting. And then there's a lateral suboccipital approach, which is often used for decompression of cranial nerves and provides access to lateral cerebellar lesions of the cerebellopontine angle, and vascular region of the posterior circulation. For this approach, the patient may be placed in the lateral decubitus or park bench position or supine with the head turned. This picture is basically showing you the access that they need and how we can position the patient. All right. So now to talk specifically about, there can be multiple positions in which posterior occipital, posterior fossa tumor surgeries can be done. I'm going to discuss the two most common ones that we use in our practice. And so we're going to begin with the sitting position. So what are the cardiovascular effects when the patient is sitting? So what happens is that there's venous pooling in the lower extremities along with vasodilation and myocardial depression that accompany the general anesthesia can produce a decrease in cardiac preload, stroke volume, mean arterial pressure, as well as cerebral perfusion pressure. The cerebral perfusion pressure, as the head is raised above the heart in unanesthetized patients, the CPP decreases by approximately 15%, and the systemic vascular resistance increases by 50 to 80% to compensate. So this is what happens when the patient is awake. When the patient is under general anesthesia, this compensatory mechanism is blunted, and the patient can basically have hypoperfusion can result. Then hypocapnia associated with mechanical ventilation results in cerebral vasoconstriction and may further reduce the cerebral perfusion pressure. So again, if you're doing a sitting position, you should be aware of this concept that in sitting position, an awake patient, the CSVR is increasing to compensate for the decrease in CPP, whereas GA just blunts this compensatory mechanism, and so that's why you already have cerebral hypoperfusion. And then if you're doing a posterior fossa crani in a sitting position, there are a chance that you would be using hypocapnia, and that would it is important for you to acknowledge at the back of your mind that by causing this hypocapnia, we are causing vasoconstriction, which is going to further reduce the blood flow, and at the same time, your CPP is going to go down further. Then for the pulmonary effects, the FRC and the lung compliance increase in the sitting position compared with supine, lateral, and prone position as the abdominal contents fall away from the diaphragm. However, the ultimate effect on oxygenation depends on your cardiac output, which tends to fall in the sitting position, as we discussed in the previous slide, and may negate the beneficial effects of improved respiratory functions. Then the next the next issue that we have in the sitting position is nerve injury. So brachial plexus is at risk for stretch if the arms are inadequately supported. The ulnar nerve may be compressed at the elbow and should be padded. The hips should be flexed no more than 90 degrees, and the knees should be slightly flexed to prevent stretch injuries of the sciatic nerve. Positioning is, just on a side note, positioning is the responsibility of both the surgeon as well as the anesthesiologist. So you have to be very active when the patient is being positioned. For the most part, anesthesiologist is leading the positioning, how the patient is getting positioned, but the groundwork or the scut work is being done by the surgical team and the nursing team. And so, like I said, it's a joint responsibility. If it ever comes back as a legal matter, it's a joint responsibility, and you need to be aware of what the consequences can be if the patient is not positioned properly, and you need to make sure that all the preventive measures of standard of care for positioning were taken while you were positioning your patient. Then the next issue comes with neck flexion, the sitting position. It can lead to vascular obstruction in the neck, kinking or obstruction of the endotracheal tube, or supraglottic airway, and tongue and oropharyngeal swelling. We maintain a 2-finger breadth of space between the mandible and the sternum and position the head to avoid these complications that can happen with neck flexion, especially in long cases. And the second position that we are going to discuss today is the prone positioning. So for prone positioning, your goals are to avoid pressure on the abdomen and to minimize compression of the vena cava, abdominal contents, and associated physiologic changes. The abdominal compression in the prone position can cause, like I said, vena cava compression, reduction in venous return with resultant hypotension, venous stasis, and increased pressure in the epidural venous plexus. Then after that, in the prone position as well, there is a risk of nerve injury. So the upper extremities are at risk of peripheral nerve injuries in the prone position. They can be placed at the side of extended, they can be placed at the side or extended along the head or on arm bones. If the arms are positioned with the hands up, arms should not be overextended to avoid stretching or compressing the neurovascular bundles in the axilla. Although there are no available data to support a recommendation for the maximal degree of extension at the shoulder joint, with the arms positioned hands up, the ulnar nerve at the elbow should also be padded and make sure that no injuries are occurring to your ulnar nerve. Then in the absence of the abdominal compression, the prone position may result in beneficial effects of your pulmonary function. Then this chart is basically telling you the physiologic response that prone positioning has on your cardiovascular system. So when you make the patient prone and they're hanging and they're suspended well, and their abdominal organs are not getting compressed, and your heart is dependent, which makes it more homogeneous, and your pleural pressure gradient in the ventrodorsal and cephalocaudal planes is increased, and it leads to improved ventilation distribution. Similarly, smaller volume of dependent lung, which increases the FRC and decreases the shunt. Like I said, if the abdomen is uncompressed, then it improves the bronchial drainage, improves the ventilation, also improves the effect of areolized vents, and improves ventilation. There is a more homogeneous perfusion, less dependent perfusion, and which basically improves your VQ matching and decreases the shunt that happens in the supine position. Then what this diagram is showing, and the way we're going to explain effects of prone positioning is basically taking the example from ARDS. So if you see in this diagram, when an individual is supine, the ventral transpulmonary pressure significantly exceeds your dorsal transpulmonary pressure, resulting in greater expansion of the ventral alveoli than the dorsal alveoli. This effect is exaggerated in the ARDS, that's the acute respiratory distress syndrome, such that the ventral alveoli become over-distended and the dorsal alveoli become atelectatic. So basically in ARDS, this one will become atelectated, this will be over-distended. This is a normal phenomenon supine position, but in ARDS, this is exaggerated. What prone positioning does is basically reduces the difference between the dorsal and the ventral transpulmonary pressure, which you can see the difference over here. And once this difference is decreased, the ventilation becomes more homogeneous, leading to a decrease in ventral alveolar overinflation and dorsal alveolar collapse and recruitment of alveoli that had collapsed during the supine position. In ARDS, there is substantial ventilation perfusion mismatch in the supine position, since the blood flow and the alveolar collapse are both greatest in the dependent portion of the lung. When prone, the ventilation perfusion matching improves, since the previously dependent lung continues to receive the majority of the blood flow as alveoli reopen, while the newly dependent lung continues to receive the minority of the blood flow as alveoli begin to collapse. All right. So now you've induced the patient, you've set up the monitoring, you've induced the patient, you've decided on the positioning. Now the next step is your maintenance of anesthesia. So again, the choice of medications for maintenance of anesthesia for craniotomy should be based on the degree of pre-existing intracranial hypertension, the need for brain relaxation during surgery, the use of neuromonitoring, and the patient's medical issues.
मीटिंग अटेंड
A meta
लाइव 8 से 9 बजे का टाइम था
a meta-analysis into. I think somebody's not muted.
वो तो बड़ी घुट के मिली है तां परेशान आहो
A meta-analysis including 14 studies with over 1,800 patients who underwent craniotomy reported various outcome measures for TIVA compared with inhalation anesthesia. ICP was approximately 5 millimeter lower, and CPP approximately 16 millimeter hydrogap higher with TIVA than with inhalation anesthesia, with no difference in the operative conditions after dural opening, recovery profiles, post-operative complications, or neurologic outcomes. So, in the absence of the elevated ICP, there is no consensus on ideal anesthetic agents.
Mr. Vakkar, could you please mute your microphone? Thank you.
Thank you. So, in the absence of an elevated ICP, there is no consensus on ideal anesthetic agent, whether you want to use TIVA or inhalation agents. However, when the ICP is raised, TIVA is the preferred technique in most centers because it decreases the risk of further raising your ICP. Then this is basically the effects of the anesthetic agents on the cerebral physiology. So as you can see, your your nitrous oxide is increasing the SMRO2, the CBF, and ICP with no change on your autoregulation. Your sevoflurane decreases the SMRO2 but increases the CBF and ICP. Isoflurane also does the same with different extent, and so does desflurane. For propofol, thiopentane, it decreases your CMRO2, your CPF, and your ICP with no change in autoregulation. So the autoregulation is conserved. Same goes for your benzodiazepines. The ketamine, the CMRO2 is increased, but the CPF and ICP is unknown, and there's no change on the autoregulation. For dexmedetomidine, the CMRO2 is decreased, the CPF is decreased. And for opioids, the CMRO2 is increased and the CPF and ICP are decreased. Then, specifically in your inhalation agent, at doses below 1 MAC, they reduce the CMR and do not abolish the coupling of CPF and CMR. However, at doses above 1 MAC, these agents disrupt the cerebral autoregulation and vasodilation predominates, leading to a gradual increase in CPF and CBV with increasing doses. The other drug specifically that I've mentioned over here is dexmedetomidine, like I said previously. This drug is highly used in neurosurgery along with other aspects of anesthesia. It is a highly selective alpha-2 agonist with sedative, sympatholytic, and analgesic properties that may be administered as an adjuvant for general anesthesia or for conscious sedations for awake craniotomies. It causes a dose-dependent reduction in CBF. Then for your hemodynamic management, so the MAP should be controlled during craniotomy to maintain an acceptable cerebral perfusion pressure. What we suggest is to aim your cerebral perfusion pressure between 65 to 80 millimeter hydrocynum, assuming a normal ICP range of 5 to 10, MAP of 75 to 90 is reasonable target range for an uncomplicated patient. Outside of this range, the brain is unable to compensate for changes in the perfusion pressure, and the CPF increases or decreases passively with corresponding changes in pressure, resulting in the risk of ischemia at low pressures and edema or hemorrhage at high pressure. So we aim for a MAP above the lower limit of autoregulation with a margin of error. So as you know, the autoregulation works with the MAP of 60 to 150, and the way you calculate your CPP is basically MAP minus ICP or MAP minus CVP if CVP is greater than ICP. And so because we want to keep the CPP between 65 and 80, so a MAP of 75 to 90 would be there. And because the autoregulation goes from 60 to 150, so we would rather be anywhere around 80 is what we usually looking for our MAP. 80 to 85, so that the lower limit is, even if the patient is chronic hypertensive, you can still have that lower limit of 80 and still have the autoregulation maintained for that patient. Then how do you, these were basically what the goals should be for your hemodynamic management, and how do you achieve these goals? So you basically titrate the anesthetic agents to match the level of the surgical stimulus in order to minimize hypotensive anesthetic effects and hypertensive responses to stimulation. For the treatment of hypotension, you can initially treat with ephedrine 5 to 10, and if that is not working, then you can actually go to phenylephrine infusion to achieve an adequate CPP. You can treat a hypertension by deepening the anesthetic, and if necessary, by administering titrated boluses of short-acting vasodilators such as 5 to 10 milligram of labetalol, 20 to 50 milligram of esmolol, or if necessary, by a vasodilatory infusion of nitroglycerin of 10 to 400 mics, or nicardipine 2.5 to 15 milligram per hour. For the most part, most of our craniotomies, they are pretty low stimulant once they get in. The actual pinning and going in part is the most painful part, but once they're in, it's pretty low stimulus, so you have to change your parameters according to that to achieve these hemodynamic goals that you've set. Then after the hemodynamic goals, the next step is what are your ventilation goals? So hypercarbia should always be avoided during any craniotomy for that matter. Because the elevation in the PaCO2 results in increased CBF and may increase your ICP. Unless hyperventilation is required, we maintain PaCO2 between 35 to 38. In our clinical experience, the PaCO2 is commonly 8 to 10 millimeter higher than the end tidal in patients with chronic obstructive pulmonary disease. You can hyperventilate briefly to achieve a PaCO2 of 30 to 35 as part of your multimodal approach for brain relaxation. The third step is the brain relaxation. So, like we discussed in the checklist before we start the surgery, whether the surgical team wanted a planned brain relaxation, and if the brain relaxation is planned as part of the procedure, it is achieved by a combination of the following. Osmotherapy with mannitol at 0.5 to 1 gram per kg IV administered slowly. This is the most common mechanism that is used to achieving this brain relaxation, along with your hyperventilation of end-tidal carbon dioxide to 27 to 32, aiming for a PaCO2 of 30 to 35. As we discussed, there's always a difference between your PaCO2 and your end-tidal carbon dioxide. Other things that you can use for brain relaxation is a furosemide 10 to 20 and dexamethasone 10 milligram. So what you can do is, as soon as you induce the patient, is what I do in my practice, is once you've induced the patient, I basically send a blood gas and compare the difference between my end tidal and PaCO2, and then I just take that difference and keep that difference and keep measuring my end tidal, or keep aiming my end tidal with that difference. So for instance, when I sent it early, after induction, when I sent the blood gas and there was a difference of 8, or if there was a difference of 10, then I would just go 10 down the line for the end tidal carbon dioxide to achieve that PaCO2 once I have the baseline with me. Then after this comes the emergence. For the emergence, the ideal emergence for any craniotomy should be smooth, with avoidance of coughing, straining, no hypertension, and the patient should be awake enough so that an adequate neurological examination can be performed. Example, the patient should be responding to commands, moving all extremities on commands, and adequate vision and cranial nerve assessment. Then for extubation, most patients are awoken and extubated in the OR after the craniotomy. Extubation may be delayed if there are concerns for cranial nerve dysfunction that might impact airway reflexes. The plan for extubation should be discussed with the surgical team, along with the other things that we discussed in the beginning. When do we need a delayed extubation? Patients with pre-existing laryngeal muscle dysfunction, dysphagia, or respiratory compromise may be unable to maintain or protect the airway after extubation, particularly with any residual anesthetic effects. So patients with pre-existing neurological deficits, patients with an extent and location of surgery in which the surgical location was at a place that they think the nerve might be damaged and my patient might not be able to maintain his airway. Or if the patient has airway edema related to positioning, then you can think about a delayed extubation. Then one of the things that can happen after the surgery is done is a posterior fossa syndrome. It may develop immediately after surgery. It includes dysarthria, cranial nerve deficits, hypotonia, and dysphagia. It affects the patient's ability to maintain the airway. It is rare in adults, but can occur in 29% of children undergoing posterior fossa syndrome. For the postoperative part, you need an ICU stay postoperatively for serial neurologic examinations and rapid response to abnormality. You need continuous blood pressure monitoring and control, which can also be provided in the ICU stay, and the ICP monitoring if required, along with treatment of pain and posterior PONB. Thank you.
Thank you very much, Dr. Imran, for presenting such a nice lecture. Now, I would ask the participants to ask any question if they want to. I think there are a few questions in the chat box.
So the first thing is the pace. So it was a very big topic, and so I had to cover a lot of things. So the presentation was quite big, and so I had to go a little fast. Yes, I'm happy to provide the slides. I have no issues in providing the slides. What's that?
Dr. Ramla has asked that ketamine increases the ICP according to Atkin head. Would you comment on that?
Yes. So there are multiple studies that have been done for ketamine multiple times. Some studies, as I said, there's a conflicting data. Some studies show that it increases ICP. Other studies show that it does not affect much ICP. There's nothing in conclusion that can be said. If Atkinhead is saying that it increases ICP, then for your exam purposes, that is what I would go with. Ocular injuries and proning. So ocular injuries and proning, so again, it depends on it relies on the positioning. So you have to make sure when you position the patient that there's no pressure on the eyes. One, you need to keep checking your position every half an hour. So usually the way we do it is there's a mirror under the mirror as part of the headdress for the prone positioning, and so you can keep seeing the eyes and make sure that there's no pressure on the eyes. The other part is your map, to make sure your map is high. That is more related when you're doing spine surgery for the map, but still for these prone position as well, we just keep our map high and keep making sure that the eyes are not having excess pressure.
And Dr. Pardeep has asked that what are other causes of decreased ETCO2 other than VAE?
So anything that is affecting your ventilation. So for example, your cardiac load, your machine, for example, you're having disconnection, right? Or a leak. If you're having a leak, that would also decrease. If you're having a disconnection, that would decrease your end tidal. If you're having any cardiac issues, that would decrease your blood supply, and that would decrease your end tidal along with that. So can you please explain extubation?
Dr. Arbab is the question. Sir, can you please extubation again? Usually we do extubation in deep plane. Where it goes. When patient gain its respiratory effort, but not awake, to avoid straining and to avoid sympathetic response. What will be your opinion on this?
So how I awake my craniotomy patients is I have 2 syringes, one of Libertolol, to maintain my blood pressure. So usually by the end of the surgery, I just talk to the surgical team and say, what blood pressure do you want it below during extubation? And most of the time it's around 150. So I make sure that the blood pressure doesn't go up while the patient is waking up. I had the patient on Remi infusion, but at a very low dose. So I have them on 0.02 mics per kg per minute when I'm trying to extubate them. And then depending whether it's TIVO or whether it's SIVO, once the propofol or the SIVO is out of the system, if you have a good REMI and a good pain control, you tell the patient to open the eyes. For the most part, they open the eyes and you just remove the tube. So I prefer to do an awake extubation, fully awake extubation with REMI on board, which would just keep them happy and pain-free for the most part. But I do want them to be awake as quickly as possible. And for the most part, we do the neurologic examination before we leave the OR.
And Dr. Kabiru Issa has asked, what are the steps to be taken when VAE occurs?
Post-operative ventilation benefits.
What are the steps to take when
what are the
VAE
steps
occurs?
to take when VAE occurs?
Yes.
Hemodynamic stability. So do everything that you can do to maintain your hemodynamic stability. The surgeon can do a saline shower on the area. If you have a CVC, central venous catheter, you can try and aspirate the air. If you have a TE or precordial showing you the air, then you can try and aspirate that. But for the most part, it's hemodynamic stability that you need.
I don't think we have any other questions. Participants. Yes, please. Please go ahead, please.
Have you? Oh no, I was seeing one of the question was, could you please revisit the extubation process of such cases? So it depends again whether I'm doing CO maintenance or I'm doing a propofol maintenance. If I'm doing a propofol maintenance, when they start to close, I decrease my propofol to 50 or 30, and I keep looking at my neuromonitoring guy to give me a number that I want of my BIS. As long as I have that number between 40 and 60, I maintain my propofol at that point. And like I said, I just cut down my REMI to 0.02. Dressing. They ask for wet and dry from the nurse. that does is that they can put the dressing on, they can put that headband on, whatever they need. And then once they're removing the pins and they're moving the neck, patient gets stimulated and starts to wake up. And at that point, I'll just extubate the patient.
And the same question on VAE from Muhammad, where it goes, Muhammad Wahid. What about position and treatment of VAE? We should tilt patient to left side or not, sir?
Yes. Yeah. So it depends what part of surgery you are in, right? So if it's at a part that you can actually safely move the patient, if the patient is sitting, because mostly it happens in sitting, the VAE. So if it is safe to do so, yes, you should change the position, but and put the head down. But a lot of the times that's not possible.
And again, incidence of VAE in
I
sitting
don't
position.
remember. I don't have it on the top of my head, the incidence of VA in sitting position. Have you experienced a VA in your career? I did once when I was a resident, but I was a very junior resident at that time. I did experience at that time.
And the last question is,
So ideal
what's the
muscle
ideal
relaxant
muscle relaxant?
depends on. Yeah, so the ideal muscle relaxant depends whether you are doing an MEP or not, right? So if you're not doing an MEP, then if you're doing an MEP, then you're not going to use any muscle relaxant. You're only going to use muscle relaxant at the beginning. It doesn't matter which muscle relaxant you use because they all have minimal effects on all cerebrovascular. Like I said, because of the access or ease of Sugabenex, everybody prefers rock. Just because if you're not into can't ventilate, you have Sugabenex right at the back. Give it and reverse your rock.
Okay, thank you very much, Dr. Imran, for such a nice lecture. Your lecture took me into my past, when I used to anesthetize a lot of these neurosurgical patients, and it has been ages.
I know.
The things have changed enormously, with the medicine, everything. Anyway, it was really such an informative lecture, and I hope that new cabinet of PSA Karachi will carry on this series of lectures. I would ask Dr. Komal, who is conducting the lecture, to give her remarks, then we can conclude the session.
Thank you so much for inviting me, Dr. Jawari. I've always... Sorry?
I had a question, sir.
Yeah, go ahead.
We didn't mention the ocular injuries occurring in the prone positioning, sir. Because in neurosurgery, these are very much frequent, sir. So can you please put some light on this issue, sir? Ocular injuries during prone positioning, sir.
So ocular injuries itself, yes. So ocular
I think
injuries
we've already explained it. I think
it's not a topic that I could have covered in posterior fossa.
Yes. And
I didn't include it in my presentation.
And a concluding remark from Dr. Pardeep that he's looking forward for another lecture soon. Definitely, Dr. Pardeep, we will continue our legacy, of conducting these lectures. We have already entered into our fourth season, and that means it's in fourth year, and we'll continue it with the new cabinet, inshallah. And Dr. Komal, could you please give your remarks before concluding the session? I think she's not present. Anyway, thank you very much, Dr. Imran. Thank you very, very much. And
thank you, Jawari, sir. Thank you so much for inviting me.
And probably, I don't know whether we'll be able to meet in the conference in Karachi or not, because I haven't seen your name in the participants.
No, I won't be coming in April.
Anyway, sometime very soon, inshallah. Thank you very much, Dr. Imran. Thank you very, very much.
Thank you, sir.
Okay.
Allah
See you
Hafiz.
then. Allah Hafiz. Allah Hafiz.